Hello everyone. Hi, I am Dr. Arun, clinical pharmacologist. So all of you will be aware of my videos and teaching sections on the clinical pharmacology CPT Pandora. Today I am reviewing on a topic on drug-drug interactions in clinical practice. So common drug-drug interactions encountered, clinically relevant drug-drug interaction encountered in clinical practice. So I will be reviewing these sections under this sections as introduction, concept of drug interaction, types of drug interaction, PKPD interactions, relevance in clinical scenario, common drug interaction and implications, and drug interaction, chest medicine, antitubercular drugs and antibiotics, and polypharmacy, and relevance and rational drug therapy and significance, pharmacogenomics and drug interaction. So these are the things reviewing in this section. So let's talk about each in detail. So what is a drug-drug interaction? It's a modification of response of one drug by another when they are administered simultaneously or in quick succession. So response mostly quantitative, either increased or decreased, or qualitative by altered response. So drug interaction increases with polypharmacy. Clinical scenario, the drug interaction are more relevant in patients receiving multiple drugs in multiple comorbidities, especially in old age or geriatric age groups or patients in ICU with multiple comorbidities. This drug-drug interaction is clinically significant. So some examples are SC inhibitors with the diuretic. SC inhibitors means antihypertensive, diuretic also antihypertensive. So it will potentiate each other's action by synergistic action. So SC inhibitors, some examples, captopril and elaborate diuretic, furosemide, spironolactone like drugs. Sulfamethoxazole and trimethoprim both are bacteriostatic drug, but if it is combined, the Bactrim DS double strength or cotrimoxazole is a bactericidal action. So it is used to treat bacterial infection. Furosemide amyloid combined to prevent hypokalemia. Ritonavir or other ART combined to increase the action of other ART by inhibition of metabolism of other ART by the ritonavir. So these are the possible drugs that is notorious for drug-drug interaction, clinically significant: anti-diabetic, angina, antiepileptic or CBs, anti-asthmatic, antipepticals, anti-TB drugs, antihypertensive, anti-Parkinsonian, anticoagulant like drugs, anti-HIV drugs, etc. So which are the high risk clinical settings for drug-drug interaction or drug-food interaction? Especially when we are using drugs in patients with multiple comorbidities like liver disease, kidney disease in ICU, or in old age patients receiving with multiple comorbidities receiving narrow therapeutic index drugs. One of the narrow therapeutic index drug is Warfarin like drugs. Other examples are anti-cancer drug like fluorouracil, immunosuppressive drugs like cyclosporin, tacrolimus, antiarrhythmic drugs like quinidine, anticonvulsant like phenytoin, OHA like glutarate, aminoglycoside like gentamicin, glycopeptide antibiotic like vancomycin, antiretroviral like acidopyrin, antifungal like amphotericin, others like lithium. So if you consider the drug-drug interaction, the main three types of drug-drug interaction is: one is PK, second is PD, and third is drugs while mixing. Pharmacokinetic is this alter the concentration of drug at the site of action by affecting its absorption, distribution, metabolism, and excretion. If you consider the PK drug interaction, it can occur at the four phases: one, absorption; second, distribution; third, metabolism; fourth, excretion. In absorption phase, there is an alteration of absorption or first-pass metabolism. In distribution phase, there is drug displacement from plasma protein or role of P-glycoprotein inhibitor. In metabolism phase, inhibition of metabolism or induction of metabolism, and excretion phase at the level of tubular secretion or excretion. So we are moving on to and the absorption phase. What are the possible drug-drug interaction? Common examples are: if you give calcium or iron or salt or antacid or sucralfate with a tetracycline, it will causing insoluble poorly absorbed complexes. so it will hinder with absorption of tetracycline. If you give sucralfate with phenytoin, it will absorption decrease due to binding of gastrointestinal limit. If you give H2 blocker, proton pump blockers with ketoconazole, itraconazole, posaconazole, it will decrease gastric acidity, so it will decrease absorption of these drugs. If you give ampicillin, tetracycline, cotrimazole along with the oral contraceptive pills, it will interfere with the enterohepatic recirculation, so it will decreases oral contraceptive concentration in the circulation, so it will causing contraceptive failure. In distribution, if you consider the interaction, it will cause the displacement of one drug from the binding site of plasma protein by other drug. Example is liable drugs are oral anticoagulants like warfarin, sulfonylurea drugs like stolbutamide, some NSAIDs and antiepileptic drugs like phenytoin, which are highly plasma protein bound. Display drug may be in the free active form initially, so it will lead to toxicity. Effect is only transient. If you give quinidine with a digoxin, so reduced binding of digoxin tissue protein by result and decrease renal and biliary clearance by inhibiting beta-glucan by the quinidine, so it will lead to digoxin toxicity. Metabolism, if you consider the affecting the bioavailability of one plasma half-life of drugs, it can be either inhibition of drug metabolism or induction of drug metabolism. Inhibition is due to competitive action for the same CYP or 50 isoenzyme or cofactor. So inhibitors of metabolism, multiple drugs are involved. CYP metabolism, antibiotic like ciprofloxacin, macrolide, metronidazole, chloramphenicol, quinaprisin, dalfaprastin, antifungal, ketoconazole, itraconazole, posaconazole, and voriconazole. And HIV protease like inhibitors and SSRIs and cimetidine. And inducers, some of the examples of inducers is antiepileptic like phenytoin, carbamazepine, barbiturates, antitubercular drugs like rifampicin, rifabutin, isoniazid, and others are chronic alcohol, cigarette smoking. And CYP enzyme inhibitors, if you consider the ciprofloxacin will inhibit CYP1A2, erythromycin, CYP3A4, antifungal like fluconazole, ketoconazole, itraconazole will CYP3A4 inhibitors, grapefruit juice also CYP3A4 inhibitor, isoniazid is CYP2E1 inhibitor. And some inducers are barbiturate will induce CYP2B, charcoal boiled egg CYP2E1, dexamethasone CYP2E1, ethanol chronic alcoholism because the induction of CYP2E1, rifampicin, rifabutin, CYP3A4, etc. And these are the examples for CYP3A4 inhibitors. Some are antiarrhythmic like amiodarone, antibiotic like clarithromycin, diltiazem, erythromycin, fluconazole, imatinib, hexakinase, ritonavir, indinavir like drugs, itraconazole, verapamil like drugs. Some this in details of substrate induced inhibitors CYP3A4 example, carbamazepine is a substrate. It is induced by phenytoin, it is inhibited by erythromycin. Another one, tacrolimus is a substrate, it is inhibited by retroviral. CB1A1A2, caffeine is a substrate, cigarette smoking inducer, ciprofloxacin is inhibitor. CP2C19, diazepam is a substrate, phenytoin is an inducer, and diazepam itself is an inhibitor, or fluoxetine is a methyl is an inhibitor. 2D6, amitriptyline is a substrate, fluoxetine, paroxetine, sertraline like SSRI and venlafaxine is inhibitor. And CF2E1, halothane is a substrate, ethanol, isoniazid, phenobarbital are inducers. So some of the, now we will discuss some of the examples for the drug-drug interaction that is commonly encountered in the clinical practice. One is failure of antibiotic therapy with doxycycline and metronidazole, chloramphenicol due to the long-term medication with inducing agents, contraceptive failure due to enzyme induction, toxic dose paracetamol lowered in chronic alcohols due to enzyme induction. Then the common drug interactions noticed in PK interaction noticed in excretion level is if you give probenecid along with the penicillin furazole, it inhibits the tubular secretion along the behalf of penicillins. If you give diuretic tetracycline inhibits the NSAID with the lithium, it will promote the tubular reabsorption of lithium, increase the level of lithium. If you give probenecid with aspirate, it will abolish the action of probenecid. And pharmacodynamics drug interaction, it enhances response in just attenuate response is antagonism or abnormal response. Concurrent administration benzodiazepine with antihistamine or neuroleptic or opioid without drinking alcohol behavior cause excessive sedation, respiratory depression, motor irritability in coordination. Then concurrent administration of alpha and adrenergic blockers or vasodilators inhibitors with high ceiling diuretic and cardiodepressant causing excessive fall in BP. If propranolol co-administered with insulin sulfonyl urea directly, it will cause a hypoglycemic unawareness due to blockage of beta adrenergic receptors. If a ceftriaxone is added to the oral anticoagulants in circulation, it will additive prolongation of prothrombin and bleeding time due to displacement of oral anticoagulant from the plasma protein. Simultaneous use of aspirin, diclofenac, clopidogrel, carbamazepine causes platelet inhibition causing bleeding. Concurrent use of antiplatelet anticoagulant causing excessive bleeding. Propranolol given in digital patient causing marked bradycardia. Sildenafil when given along with organ nitrate, it will increase the generation of cyclic GMP and it will cause a precipitate fall in BP and myocardial infarction. Concurrent use of AC inhibitors in potassium sparing diuretic will cause severe hyperkalemia. If aminoglycosid antibiotic is given along with another ototoxic drug like furosemide causing additive ototoxicity. Some of the drugs like beta-lactam antibiotic combined with tetracycline erythromycin and will causing antagonistic bactericidal action. Mutual antagonist of antibacterial action of bacterial and glycamiciclorophenicol due to interference with others binding in bacterial 50S ribosome. Reduction antibiotics action of clonidine may permit possibly due to blockage of central action of clonidine. An attenuation of antihypertensive effective AC inhibitors of beta blocker or diabetic inhibition of chronic prostaglandinosis. So blending of potassium considering action of spironolactone by aspirin inhibiting tubular secretion of candreniol. These are some examples of the drug-drug interaction that is commonly known in clinical practice. Another one is levodopa with the neuroleptic and metoclopramide having antidopaminergic action. It will abolish the action of antiparkinson's drug levodopa. The basics of certain interaction is not aspirin like ampicillin when given with the allopurinol, increase incidence. Hyperuricemia. So drug interaction before administration, that is physical mixing of the drugs will causing interaction and due to chemical reaction. So certain drugs react with each other and get inactivated if their solutions are mixed before administration. Example penicillin G, ampicillin with gentamicin, aminoglycoside like drug. Thiopurine and sodium with succinylcholine or morphine. Heparin with penicillin, gentamicin, hydrocortisone. And noradrenaline with the sodium bicarbonate solution. So we have already know that the polypharmacy is a main with the multiple drug administration is a main culprit in the drug-drug interaction leading to compromising the therapeutic efficacy and safety all levels. So these are the examples of drug-drug interaction. Antibiotics we have already explained. Then antitubercular drugs with metronidazole, doxycycline, chloramphenicol, warfarin, protease inhibitors, corticosteroids, OCP, sulfonylurea, antidepressant, theophylline, it will cause loss of efficacy of objective drugs. So induction of metabolism and drug and it will causing efficacy, loss of efficacy. Pharmacillin, diazepam and other benzodiazepines saccharide CNS depression. Phenobarbital, phenytoin, carbamazepine with other drugs causing loss of efficacy due to objective drugs, induction of metabolism. Then at the level of NSAIDs, you can see this gastrointestinal system, these other interactions, psychopharmacological agents, antihypertensive agents, the pharmacillin versus antiretroviral drugs. So this antiretroviral drugs versus antitubercular drugs is a nice diagram showing the drug-drug interactions. The green is showing no clinically significant drug interactions expected between these drugs. Red showing that this drug should not be co-administered. And orange is showing the potentially clinically significant interaction that is likely to require additional monitoring or pressure drug dosage timing of the administration. And yellow showing potential interaction likely to be weak of intensity, additional action or monitoring or drug adjustment is unlikely to be required. So these are the table representing the drug-drug interaction between antitubercular drugs and antiretroviral drugs. Okay, now move on to So this slide we have already discussed. So pharmacogenomics has a very important role in the drug-drug interaction by altering the metabolism of the drugs, either by upregulating or downregulating the CYP enzymes, or affecting the absorption by affecting the peak glycoprotein level, or at the level of excretion. Anything that can happen at the channels due to the apparent channels, or upregulated or downregulated ionic channels. So that it will result in drug-drug interaction, potential toxicity or therapeutic failure, that we will discuss in another section in detail. So by this I am concluding my lecture on drug-drug interaction in the common clinical practice that will be relevant to the routine clinical practice and help them in early identification of the adverse drug reaction due to drug-drug interaction and early identification of the therapeutic failure due to drug-drug interaction and replacement with suitable alternative agents or regimens. So thank you. So any doubts you can put comments on the chat box. I will reply to the comments. So I will continue with my lectures on clinical pharmacology in different domains, including the drug-drug interactions on the oncoming sections. So once again, thanking you all and concluding my section. Thank you.